Okay, friends, welcome uh, to this session of One Shot Revision. I am Dr. Ajay Yadav, and today we are having one shot revision of anesthesia. Okay, so without wasting any time, let's straight away come to the point. Let's start our discussion. So, anything in the life begins with the history, so we'll also start with the history. And in history, obviously, for anything, history is very vast, but you need not go in the details of the history. So, the two most important thing in history that you should know, and they can be asked from you. One is the first public demonstration of anesthesia. So, one thing I like to tell you here is that uh, I'll be loading PDF notes. So, don't try to make notes here because it's just a one shot revision. So, just try to understand, and you will be getting PDF notes later. So, otherwise, it's not possible to make notes. Otherwise, we're going to waste a lot of time. So, first public demonstration of general anesthesia that was given by Morton on 16th October, and that is why today we even today we are celebrating 16th October as World Anesthesia Day. So first public demonstration of anesthesia was given by Morton, and that was on 16th October, and that's why even today we are celebrating 16th October as World Anesthesia Day. Then the second most important landmark which you must know is first spinal anesthesia in human beings. And first spinal anesthesia in human beings was given by August Bayer. So these are the two important points in history that you should know. First public demonstration of anesthesia, that's by Morton on 16th October. And first spinal anesthesia, that was by August Bayer. And a very interesting fact about this is that August Bayer gave this spinal anesthesia on himself. Means he subjected himself, and it was given by one of his friend. She was physiologist. Then coming to the next part, that is anesthesia delivery systems. So as the name suggests, it means the systems or the equipment which we are using for the delivery of the anesthetic gases to the patient. So to deliver a gas, we should have a source. So there should be a source. Only if you have source, then only you can deliver something. From source, gases will reach the anesthesia machine. And what important process happen in anesthesia machine, that we will see. And after processing these gases through some these tubings, which are called as breathing circuits. So through these breathing circuits, obviously gases are going to reach the patient. So first we'll see the sources, and then we'll see what actually happens in anesthesia machine, and then about the breathing systems. Fine. So source of gas can be cylinder. Most often used source is cylinders. So regarding cylinders, two most important thing that you should know. One is the color and second is the pressure. So that is the two most important thing about cylinder that you should know. So color of oxygen cylinder is black body with white shoulder. And color is not only important from questions point of view, color is also very important from clinical point of view because color is the only criteria to identify a cylinder. So color of oxygen cylinder is black body with white shoulders, that you can see also. And many of you would have seen cylinders also. Regarding pressure, there are so many units you may find in your books, but forget about those units. Different countries are using different units. You just remember the most commonly used unit in India, that is pounds per square inch. PSI means pounds per square inch. So the pressure in oxygen cylinder is 2000 pounds per square inch, 2000 psi. Then second cylinder in common use is nitrous oxide, which is stored in blue color cylinders. You can see blue color cylinder at a pressure of 760 pounds per square inch. Third cylinder that is sometimes used and can be asked from you is Antonox, which is a mixture of 50% oxygen and 50% nitrous oxide. So the color is blue body with blue and white shoulders. So this blue body with blue shoulders indicates nitrous oxide and white shoulders indicates oxygen. And the pressure is same that of oxygen, that is 2000 psi. And that's the rule of physics that if we mix two gases at different pressure, the combination always exhibit the pressure of higher gas. That is why Antonox is exhibiting the pressure of oxygen, that is 2000 psi. So simple. Oxygen color is black body with white top or white shoulders. Pressure is 2000 psi. Nitrous oxide blue color cylinders at a pressure of 760 psi. And Antonox, which is a mixture of 50% oxygen and 50% nitrous oxide, has blue body with blue and white shoulders, and the pressure is 2000 pounds per square inch. Then one more thing about cylinder that you should know is the pin index system. Actually, pin index system is nothing. This is a system of pins and holes. Pins at anesthesia machine and holes in cylinder. So this is a system of pins and holes which prevent the wrong fitting of cylinders at the anesthesia machine. Because if you fit a wrong cylinder, say I fit nitrous oxide at the place of oxygen and patient receive 100% nitrous oxide, patient is definitely going to die. So basically pins on the anesthesia machine and holes on the cylinder should match, then only cylinder can be fitted at its place. Like for oxygen, the pin index position decided is 2 and 5. Means if this is a place where oxygen cylinder is going to be fitted, so the position of these pins will be 2 and position is 5. And if this is an oxygen cylinder, then the position of the holes will be 2 and the position of holes will be 2 and 5. Now, nitrous oxide cylinder, say if this is a place for nitrous oxide cylinder, then this position will be changed from 2 to 5 to 3 to 5. Means these are the 7 pinpoint positions they have decided. 3, 5. And if this is a nitrous oxide cylinder, the whole position will be 3 and 5. So with the position, whole position of 3 and 5, can you fit nitrous oxide cylinder at the place of oxygen, which has pins at place of 2 and 5? Of course not. So therefore, pin index system is basically to prevent the wrong fitting of cylinders. And pin index position very frequently asked, so you have to remember. Defined for oxygen is two pins are at a position of 2 and 5. Nitrous oxide, the two pins are at a position of 3 and 5. So this is not 2 and 5, you can correct it. At nitrous oxide, the pin position is 3 and 5, not 2 and 5. You can correct it. Printing error. 3 and 5. Air, normally air we are not using through anesthesia machine, but by chance if they ask you, then it is 1 and 5. However, not that important from your point of view to remember. And Antonox you can see has only single pin at a position of 7. So these three you can remember. Oxygen pin position is 2 and 5. Nitrous oxide pin position is 3 and 5. And Antonox pin position is 7. And I told you this pin index system is to prevent the wrong fitting of cylinders on anesthesia machine. Then okay. Then another source may be central supply. Sometimes gases are coming through central supply. There is a central supply room, and through pipes, gases are coming directly to anesthesia machine, so that you need not change cylinders very frequently. If your consumption of gases is more, Obviously, you cannot cylinder very frequently. So gases are coming through central supply. Through central supply, gases are supplied at a pressure of 60 pounds per square inch. 60 psi. So simply you can say now our sources of gases can be cylinders or can be central supply. So from the sources of the gases, obviously gases are being delivered to the anesthesia machine. Now basically in anesthesia machine, this is anesthesia machine, two will not go in details. Two most important thing which happens in anesthesia machine is, in fact, three things I will say. One is the pressure reduction. Cylinder in oxygen cylinder has a pressure of 2000 psi. Can you imagine 2000 psi can blast anything? Forget about patient. So obviously pressure has to be significantly reduced. So there are systems in the anesthesia machine which will reduce the pressure. Second thing is you can set the flow rates. How much liter of oxygen I should give, how much liter of nitrous oxide I should give, that you can set with anesthesia machine. These are the knobs. By rotating these knobs, you can set flow in these tubes. So you can see how much flow you can set. Say I want to give 5 liter of oxygen. So there are markings in these tubings. So I will keep it at 5 liter, then 6 liter like that. So I can set the flow rate simply. And third thing is addition of volatile agent. Volatile agent can be anything. Halothane, isoflurane, desflurane. We'll discuss this in detail later. So this you can see this instrument. This is called as vaporizer. So vaporizer is the instrument which is used to deliver volatile agents. So three things which happen in anesthesia machine. Pressure get reduced. Secondly, flow rate you have set. And thirdly, you have added the volatile agent. So this is what all happens in anesthesia machine. So here I told you, here three things will happen. There will be pressure reduction, there will be addition of volatile agent, and you can set the flow rates. So after this, now these gases from anesthesia machine will deliver to the patient. And for that delivery, you need some tubings, breathing circuits. These tubings are called as breathing circuits. So breathing circuits are nothing. These you can say are the tubings which connect anesthesia machine to the patient. Now there are different types of breathing circuits. Again, not possible in one short revision and not that much required for you also. So simply we can see breathing circuits are the connection. These are just tubings. You can see these are just tubings which are connecting anesthesia machine to the patient. So breathing circuits broadly for your point of view, you can remember they can be classified as semi-open and circle system. Just two things you can remember. Fine. Semi-closed or closed, which are called as circle system. I will tell you, don't worry. Don't get scared while looking at the names. We'll discuss when you little understand it. Semi-open. So this semi-open circuits, they were described by the scientist Maffelson. So they are called as Maffelson circuits. As the name suggests, what do you mean by semi-open? Means gases are being, some gases are reused, or you can say some gases go back into the tubing while some gases are venting out into the atmosphere. So that is semi-open. So semi-open circuits were described by Maffelson. You can simply remember. So Maffelson described these circuits actually from A to F. A to F. So this is Maffelson A, which is also called as McGill circuit. So this will be connected to the patient. This end will be connected to the patient. And this end will be connected to the anesthesia machine. So anesthesia machine, gases from anesthesia machine, like say I'm drawing them as green. So they, through this tubing, will reach the patient. Now, expiratory gases, which I am showing here blue, majority of these expiratory gases are going to vent out into the atmosphere through this expiratory valve, while some gases can go back into the tubing. And that is why we call them semi-open, venting out into the atmosphere, while some gases are going back into the tubing. But these gases, we don't want that patient should re-inhale. So therefore, we should keep enough fresh gas flow. Fresh gas flow means the gases coming from anesthesia machine, fresh gases. So these gases should be sufficient enough to vent out these expiratory gases into atmosphere and then to be delivered to the patient. Again, if you don't want to go in those details, forget it, because it's a big, you can say physics is required, and obviously we don't have that much time to discuss. What is important for you to remember from your point of view is that this McGill circuit is the circuit of choice for spontaneous ventilation. See, patient during anesthesia may be spontaneously breathing, or most often the patient is paralyzed by giving muscle relaxant. So ventilator controls the ventilation of the patient, that is controlled ventilation. So if patient is spontaneously breathing, we will prefer McGill circuit. So it is a circuit of choice for spontaneous ventilation. And fresh gases, that means gases coming from anesthesia machine, they should be kept equal to the minute volume. This is the recommendation for McGill circuit. This is the recommendation, and how it is set again beyond your scope. So fresh gases means gases coming from the patient should be equal to minute volume. So what is the minute volume of the patient? Tidal volume into respiratory rate. Tidal volume is how much? 500. Respiratory rate is 12. So you can say 6 liter. So if you are using McGill circuit, the gases coming from anesthesia machine should be set at 6 liter. So that is how we can set these flow rates in anesthesia machine. Fine. Then B and C, obsolete. A modification of Mephelson D, that is Baines. A modification of Mephelson D is most commonly used circuit. So this Baines is most commonly used type of semi-open circuit, and it is coaxial. Coaxial means they have incorporated an inner tube into outer tube. Coaxial, one tube passing through the other. So why? Because this end will be connected to the anesthesia machine. So fresh gases will pass through the inner tube. Can you see this inner tube inside green color? So fresh gases will pass through the inner tube, and expiratory gases, which I'm showing here as blue, through the outer tube. Means there will not be any mixing of the gases in the tube. Otherwise, in McGill, you can see the gases, fresh gases and expiratory gases can mix. But here, there is no mixing, so this circuit become very, very popular, so and so that it is most commonly used. And it is the circuit of choice for controlled ventilation. Controlled ventilation, I told you, means you have given muscle relaxant, patient is paralyzed, you or ventilator is controlling the ventilation. And in that case, fresh gas flow coming from anesthesia machine should be 1.6 times of minute volume. What is minute volume? 6 liter. 1.6 time of 6 liter means approximately 10 liter from flow from anesthesia machine you are going to keep. Then Mephelson E is T piece, but it was an incomplete circuit, so not used. A modification of E, that is Mephelson F, is the most commonly used pediatric circuit. And this Mephelson F is also called as Jackson-Rees. Jackson-Rees. Okay. So let's summarize these semi-open circuits. What are circuits? Which connect anesthesia machine to the patient for the delivery of anesthetic gases. So broadly from your point of view, these you can say circuits are two types, semi-open and circle system, semi-closed or closed, that we'll discuss later. So semi-open, they were discovered by the scientist Mephelson So they are also called as Mapleson circuits. And Mapleson have classified these circuits from A to F. Mapleson A is also called as McGill circuit, and it is a circuit of a choice for a patient who is spontaneously breathing. And fresh gas flow, that means gases coming from anesthesia machine, should be equal to minute volume. B and C, obsolete circuit, a modification of D, that is Baines, is most commonly used semi-open circuit, and it is a coaxial circuit, means one tube passing through the other, and the circuit of choice for controlled ventilation, and fresh gas flow coming from anesthesia machine should be 1.6 times of minute volume. Mapleson F, also called as Jackson-Rees because of the name of the two scientists, it is most commonly used pediatric circuit. Most commonly used pediatric circuit. Then second I told you is semi-closed or closed. What are the differences in closed, semi-closed? No need to go in that much detail. But popularly they are called as circle system. Circle system means you can see this. There is a soda line. So what will happen? These expiratory gases, drawing here blue. These expiratory gases, this is the patient. So these expiratory gases will pass through the soda lime. So what the soda lime will do? It will absorb all carbon dioxide, and the same gases will return to the patient after absorption of CO2. Circle system means the gases are in circulation. So same gases can be reused after carbon dioxide absorption. So same gases are in circulation, and gases are not venting out into the atmosphere. So we call them as closed or semi-closed circuits. Fine. Now what the most important component of closed circuit is obviously soda lime. And what is the constituents of soda lime? Calcium hydroxide 80%, sodium hydroxide 3%, potassium hydroxide 1%, water 15%, and then there is a color indicator which tells whether soda lime is fresh or exhausted. So looking at the color of the soda lime, we can tell this soda lime is fresh or has been exhausted. And why I use green pen? In fact, actually in future also, when I'm using green pen means there is some recent change. So previously used soda lime actually didn't have water. And I will tell you why they have added water. It didn't add water, but the currently used soda lime has water. So that's a major change. Now water is 15%, and they have reduced calcium hydroxide from 94% to 80%. So that is why this is the I have used green pen, means there is a recent change. In future also, wherever I'm using green pen, that's an indication that it is a recent change. Now, one of the disadvantage or problem of this soda lime is that some of the volatile agents, inhalation agents, I told you, they can react with soda lime. So we are using volatile agents, inhalation agents. I told you halothane, sevoflurane, desflurane, whatever it may be. So some of them can have reaction with soda lime to produce toxic compounds. And the most classical example of that was trilene. However, trilene is obsolete now for decades and decades. And trilene with soda lime used to produce toxic compounds which could have caused neurotoxicity or which could have produced ARDS. So therefore, trilene used to be absolutely contraindicated with soda lime in past, but it is a matter of past. But the agents which we are currently using, they can also react with soda lime to produce toxic compounds. Like for example, sevoflurane by reacting with soda lime produce a toxic compound called as compound A, which is also nephrotoxic. Nephrotoxic. Desflurane and sevoflurane, they are very dangerous with desiccated soda lime. Desiccated means dry. If soda lime is extremely dry, with the desflurane, it can produce carbon monoxide. And with the sevoflurane, it can cause burns of the respiratory tract. So desiccated soda lime is very dangerous. Desiccated means dry. With this desflurane, it can produce carbon monoxide poisoning, and with sevoflurane, it can cause burns of the respiratory tract. But fortunately, the possibility of these complications is very rare because soda lime getting desiccated is very rare for two reasons. One, when carbon dioxide reacts with soda lime, water is automatically produced. And secondly, now they have added water. Now you can understand why we have added water now in a new soda lime to prevent its desiccation. Fine. So this is all about circuits. Now let me see if there is any technical glitch or something. No, everything is fine. Great. Okay, queries we'll take later. So whatever is query comes, you can put it here, no problem. However, we'll discuss all queries and doubts later. Now, equipments. Equipments in anesthesia are mainly related to airway. And nowadays, you see there is maximum focus on emergency management. So therefore, these airway equipment management becomes really important. Embu bag. EMBU, you all know, stands for Artificial Manual Breathing Unit. Artificial Manual Breathing Unit, and this is used for resuscitation. You can see by pressing this EMBU bag through this mask, you can ventilate the patient. So this is used for artificial ventilation, and that is why it is called as Artificial Manual Breathing Unit. Then this Gudel's airway is very important part of resuscitation kit, and this is used to prevent tongue fall. Why? Because you all know that the most common cause of airway obstruction in an unconscious patient is tongue falling back on posterior pharyngeal wall and then obstructing the airway. So Gudel's airway is placed like that so that this portion lies between tongue and posterior pharyngeal wall. So preventing tongue falling back on posterior pharyngeal wall, so that way patency of the airway will be maintained. Very important device on which there is maximum chance to get question is laryngeal mask airway, LMA. So laryngeal mask airway is a device like that. You can see this tube. There is a large cuff which can be inflated with a large volume of air. And when you ventilate through this tube, can you see these ventilation holes? Through these ventilation holes, air has no option but to reach the larynx. So how it works? I'll show you also. This is LMA. It is placed blindly in oral cavity so that this part lies in oropharynx or hypopharynx. Then you inflate with large volume of air this cuff. This cuff will get inflated, will seal all oropharynx and hypopharynx. And if you ventilate through this tube, through these holes, air cannot slip anywhere. So automatically it will enter the larynx. So basically, what is the advantage of LMA? Basically, the main advantage of LMA is that you can use as an alternative to intubation. Emergency say you are not able to intubate. You can put laryngeal mask airway. And secondly, we are also choosing electively to avoid the complications of intubation. Endotracheal tube. Intubation has plethora of complications. So to avoid these complications, we can use laryngeal mask airway. And over the years, when we are using LMA, we find it so effective method of ventilation that nowadays routinely, very commonly, we are using as an alternative to intubation to avoid the complications of intubation. However, the most major disadvantage is this LMA has not blocked the esophagus. You can see it just lying above the esophagus. So air can still leak from the sides. enter the esophagus, increase the intragastric pressure, increasing the risk of aspiration. So that is a disadvantage of LMA, that it increases the risk of aspiration. So obviously it will not be suitable for the patient who are full stomach and are at high risk of aspiration. And another problem is you are clearly seeing that air is leaking from the side and patient's stomach is getting distended. Now you cannot deflate the stomach also, from where you will pass your suction catheter Rayleigh tube, because cuff of the LMA has occupied the oropharynx. So from where you will pass your suction catheter or Rayleigh tube. So that is also a limitation. However, this problem is not there because nowadays we are actually using a new generation, that is second generation LMA. And second generation LMA, the main advantage is that there is a separate tube for gastric deflation. And the prototype of this second generation LMA is ProSeal. So you can see it's a second generation LMA. So there is a separate tube for gastric deflation. So through this tube, you can pass your suction catheter or nasogastric tube, and through this tube, through this hole, this will enter the esophagus and you can deflate the stomach. Then there are many cuff related problems, like accidentally cuff get deflated. So LMA can rotate and can itself can cause obstruction and may come out. And when you are removing the LMA, patient may bite this cuff. So to avoid these problems, very commonly used is a pre-filled cuff LMA that is called as iGel. So you can clearly see the cuff is pre-filled with a gel. So all this cuff related problems can be avoided because it's already filled with a gel. We need not fill it with the air. So there is no chances of deflation. Eye gel. So this eye gel is also very commonly used. Then another kind may be LMA Supreme. So LMA Supreme, the advantage is that there is a bite block. You can see. Otherwise, what can happen? Patient can bite this tube and that can cause obstruction. So there is a good bite block. So patient cannot even bite the tube of laryngeal mask airway. That is a main characteristic of LMA Supreme. There are other also, and I think that was a question in FMG also. I think 2 years back they wanted to ask that what the most important characteristic of LMA Supreme from ProSeal. Fine, so it has got bite block. Now face mask, obviously face masks are used to ventilate the patient. However, they can be used only transiently till you are able to either intubate the patient or at least put laryngeal mask airway. Transient period you can increase, you can use LMA till you don't have a definite method of ventilation. So for transient period, you should use face mask because there are many disadvantages of mask ventilation. But the most important that you should remember is that it tremendously increase the risk of aspiration. Not only increase, tremendously increase. Why? Because with mask ventilation, if you are giving positive pressure ventilation, significant air will leak into stomach, will increase the intragastric pressure, and patient can aspirate. So risk of aspiration is tremendously increased with mask ventilation. Then laryngoscope. Laryngoscope, you know, is used for enhancing or facilitating the intubation. Only do by laryngoscopy, you have to see the vocal cords, then you can place your endotracheal tube. So there are again many kinds of laryngoscopes, but the most important which you should know that most commonly used is Macintosh, and this is a blade of choice for adults. So this is a Macintosh blade. You can see it's a curved blade. So it's a curved blade, so it is best for adults. So Macintosh is the most commonly used blade of laryngoscope and it is preferred for adults. Fine. Second is Miller. Miller, you can see, is a straight blade with little curve at the tip. And we all know that there are differences in the airway of adults and children. So therefore, for children, we generally prefer straight blade. And why that? Again, because of these differences, that details will not go, not possible. So Miller is preferred for children. In books, you may find so many different answers. So what I will do, I will definitely use green pen here, because nowadays for pediatric, all age groups, children means everything, including infants, newborn, Miller is the blade of choice. And for adults, Macintosh is the blade of choice. Simple. If they ask you laryngoscope of choice for adults, you have to mention that it is Macintosh. But if they ask you laryngoscope of choice for children, then you have to mark Miller. Endotracheal tube. Obviously, endotracheal tube is used to ventilate the patient, and that is definite because you have placed a tube in trachea, so you can ventilate. So obviously, this will be connected either to your embo bag if you are doing embo ventilation, or to some breathing circuit, semi-open or closed circuit. So, and this portion obviously will be inside the trachea. So this is the machine end we say, because this is connected to anesthesia machine, and this is the patient end because it is in the patient trachea. So this is the tube which is most commonly we are using, that is polyvinyl chloride tube. This is PVC tube. So important thing which you can which you should know about this tube is, one, there is a cuff. You can see this cuff. This is the tube and this is the cuff. Now what is the, and this cuff can be inflated with this pilot balloon. So what is the actually aim of the cuff? The aim of the cuff is to prevent aspiration. Many times people think that the aim of this cuff is to prevent dislodgement of the tube, but that's not correct. Aim of the cuff is to prevent aspiration. And another very important recent change which has happened is that curved tube can be used in children. So previously we were believing that this cuff can cause tracheal wall edema, but this is unproven. It can cause tracheal wall edema in children because their trachea is soft, narrow, but that all has been unproven. Now cuff tube can be used at any age. You can use cuff tube even in a newborn. So this is again a important change on which you can expect the question. Now, there are many methods by which you can confirm the position of the tube, because if your tube is not at right place, then actually you are causing more damage to the patient than benefit. Because if your tube instead of trachea is in esophagus, then you're directly killing the patient. So you can use many methods. You can look at the chest expansion. If the chest is expanding, means your tube is in the trachea, or you can auscultate, and on auscultation you can hear breath sounds. But even auscultation can misguide you. Sometimes the tube may be in the esophagus and you are hearing the conducted sounds which you can misinterpret as breath sounds. So even auscultation can misguide you. Therefore, surest confirmation of intubation is only and only possible with capnography. Capnography, as the name suggests, is the measurement of end-tidal carbon dioxide. So capnography means you are measuring the expired carbon dioxide. And carbon dioxide will come out of endotracheal tube if only the tube is in trachea. If the tube is in trachea, then only CO2 can come out of your endotracheal tube, which you can measure in on your monitor. Now, so that is all important about equipment that you should know. Now, before starting anesthesia, we have to prepare the patient. And to prepare the patient, we have to assess the patient in preoperative period. So basically, aim of assessment in preoperative period is to diagnose if the patient is suffering from any medical disease, so that accordingly we can treat the medical disease. And based on the medical disease of the patient, we can choose our anesthesia. So in preoperative assessment, it is a complete examination, general physical examination, complete history, detailed history, same medical history that we do, auscultation of chest, heart, and personal history, smoking history, and drug history, everything, same like medical history. Additional thing that we are going to discuss here, otherwise you know how to take a history and how to do medical examination of the patient. So it is complete same. Other than that, additional thing that we do, we have to assess airway, because airway management is absolutely our responsibility. So we should be able to assess airway. And to assess airway, first thing we have to assess the mouth opening, because we are putting laryngoscope in mouth, so there should be adequate mouth opening. Otherwise, how will you introduce your laryngoscope in the patient oral cavity? And this assessment of mouth opening is done by Mallampatti scoring. So again, no need to go in details of the Mallampatti scoring. You ask the patient to open mouth as wide as possible, and looking at the structure seen, patient has been classified as class 1. Class 1 means all structures are seen. So oral intubation is easy, enough space. Class 4, nothing is seen. So obviously oral intubation is impossible. That's it. Otherwise, no need to go what all structures are seen, in which grade what structure is seen. That's not required. So simply you can remember, for airway assessment, for mouth opening, we are doing the modified Mallampatti scoring. That's it. Now, after doing your assessment, now is the aim to pre-medicate the patient. And why we want to pre-medicate? There are many indications: to prevent nausea and vomiting, or to dry up secretions, to prevent infections, so many. But there is not routine pre-medication, means there has to be some aim to pre-medicate the patient. So this is new. Previously, we are pre-medicating the patient without aim, randomly, means protocol. We have to use these medications for pre-medication, but now there should be a clear-cut indication. And as I told you, there are many indications, but most common indication for which we are pre-medicating the patient is to relieve the anxiety of the patient, because patients coming for OT are obviously very much anxious. So to relieve anxiety, we have to pre-medicate, and to relieve anxiety, obviously you can use any of our benzodiazepines. Now, another important part of preoperative assessment is that if the patient is already on some drug therapy, we have to modify. Otherwise, many of these drugs, they can have anesthetic or surgical implications. So we have to modify. And these are very frequently asked nowadays. The patient on warfarin coming for surgery, or a patient on aspirin coming for surgery, or a patient on enalapril coming for surgery, what will you do? Very frequently asked. So drugs which need to be stopped: Viagra, 24 hours. And the reason we all know that it causes sympathetic stimulation, and surgery itself is a stressful period. So if there's already sympathetic stimulation and you add further stress, that can cause severe hypertension or severe life-threatening arrhythmias. Patients on warfarin has to be stopped 5 days before. Why? You very well know, because obviously patient, if on anticoagulants, if you do surgery, they will bleed like anything. So if patient is on warfarin, that has to be stopped 5 days before surgery. Antiplatelets, if the patient is on aspirin, and this is definitely I'm going to use a green pen, very important new change, because in all books you will see it is given that aspirin to be continued. But recent recommendation is that we have to stop aspirin 72 hours before surgery, except for three situations. That is, if the patient has recent MI, has written stroke, or already there is some stent, patient already has undergone some stenting. Only in these three conditions nowadays we continue aspirin, else we have to stop aspirin 72 hours before surgery. So this is again a very important change on which you can expect a definite question. Second antiplatelet in common use is clopidogrel, that you know, available in the brand name Plavis. So clopidogrel or Plavis, we have to stop 5 days before. Previous recommendation was also 5 days. And recent recommendation is also 5 days. No change. Oral contraceptives, that is high dose estrogen. Oral contraceptives may be low dose estrogen or only progesterone. So if patient is on low dose estrogen or only progesterone, no need to do anything, we'll continue. However, if the patient is taking high dose estrogen, then we have to stop 4 weeks prior. And why? You very well know that estrogen increases the risk of thromboembolism. That is why all herbal medications, because herbal medications we don't know which kind of medicine patient is taking and which medicine have what side effect, we really don't know, and there are no studies in fact, and so liberally in India patients are taking herbal medications. So to be on the safer side, we have to stop herbal medications 7 days prior. And why I'm using green pan, because in books you may find 2 weeks before, you are stopping herbal medications 2 weeks before, but now 7 days. Again, this is a very important change. AC inhibitors and angiotensin receptor blockers are stopped 24 hours before. Rest all antihypertensives we will continue. Previously also we were continuing. So whatever the drugs which I'm not going to mention in our this list means they will be continued as such without any change. So AC inhibitors and angiotensin receptor blockers, nowadays we have to stop 24 hours before surgery. Previously we were stopping only on the day of the surgery. So this is a change. That's why I'm marking again it with green color. Smoking should be stopped 8 weeks prior to surgery. Why? Because you very well know that smoking inhibits cilia and complete ciliary recovery occurs in 8 weeks. Now, so these are the drugs which we have to stop, and already I told you the days when we have to stop, and they are frequently asked, so you have to actually have to remember also, fortunately or unfortunately. Now, doses, morning dose to be avoided for these three group of the drugs: diuretics, topical creams, and oral hypoglycemics. So diuretics, topical creams, and oral hypoglycemics we continue. Just we have to omit the morning dose on the day of surgery. Then some modifications are required. Again, for you not required also that what modification, but yes, some modifications are required in that dose regimes of cholinesterase inhibitors. Cholinesterase inhibitors means neostigmine, pyridostigmine, or steroids and anti-tubercular drugs. If LFT are compromised. If LFT are compromised, then we have to do modifications or stop, else we will continue. Fine. So these three group of the drugs, we need some kind of modifications. And one more you can add here is insulin. Insulin dose regimes also we do modifications. Now fluids. Now fluid we need for maintenance and fluid we need for replacement. Now for maintenance as well as replacement, they have made very simple. Now fluid of choice for both is ringer lactate. Again, you can expect question on this because in books you will find so many different fluid for different conditions during anesthesia, but now it all has been simplified. They simply say fluid of choice for maintenance as well as replacement during surgery is a ringer lactate, RN, ringer lactate. Now, another very important part of anesthesia before proceeding to anesthesia is monitoring, because it is your monitoring standards which decides your rate of complications. If your monitoring standards are very high, your obviously complication rate will be less. So let's see CNS monitoring. CNS monitoring means monitoring the depth of anesthesia. And the best monitor to monitor the depth of anesthesia is bispectral index, popularly called as bispectral index, BIS index. So you can see here attached to forehead and automatically calculate the score to tell you the depth of anesthesia. So for depth of anesthesia, best is bispectral index monitor. BIS index. Then cardiovascular monitoring. Cardiovascular monitoring can be just blood pressure monitoring. Now, blood pressure can be non-invasive or invasive. Non-invasive means through sphygmomanometer, automatic sphygmomanometer meters. You set the time and they keep on recording the blood pressure. Invasive blood pressure monitoring means we are monitoring the blood pressure by cannulating one of our artery. We put a cannula in artery, radial artery most often, and connect to the monitor that continuously monitor BP. So this invasive blood pressure continuously monitor the BP. So it is called as gold standard method for blood pressure monitoring. So IBP means invasive blood pressure. So invasive blood pressure monitoring is the gold standard for BP monitoring because it is continuously monitoring blood pressure, not at intervals. Then another mandatory monitor is ECG. Now ECG, there is a very big change on which you can expect a. Actually, for ECG, it is not possible to have 12 lead monitoring. So normally we are using two leads. Lead 2, which you all know that arrhythmias are best detected in lead 2. And second aim is to monitor ischemia. For ischemia, previously we were preferring V5 lead, but this is a very important recent change that lead V3 has been found to be preferred over lead V5 for detecting ischemia. Means the sensitivity of lead 3 in detecting ischemia is more than V5. This is again a standard, it means recent change. Otherwise, for decades, we were preferring V5 chest lead for detecting ischemia in intraoperative period. Now, the best is echocardiography. And echocardiography can be done through thoracic route. Normally, we are doing this echocardiography through thoracic chest, but that is not possible during surgery. So we do through esophagus. So transesophageal echocardiography means echocardiography, continuous echocardiography done through esophagus is the best monitor. You can have all cardiac functions, very sensitive for MI. You can measure cardiac pressures, chambers, everything. So excellent monitor is transesophageal echocardiography, best cardiac monitor. Respiratory monitoring. The most basic respiratory monitor you all know is pulse oximetry. We apply pulse oximeter probe. So as the name suggests, pulse oximetry means it will detect pulse as well as oxygen saturation, that is SpO2. So pulse and oxygen saturation is continuously monitored. The limitation of these pulse oximeters is that they cannot detect abnormal hemoglobin. So this is a big limitation. Means if the patient is suffering from other kind of hemoglobin, means carboxyhemoglobin, sulfhemoglobin, methemoglobin, these pulse oximeters, they cannot detect the abnormal hemoglobin. Then a very sensitive respiratory monitor I told you is capnography, which is the measurement of, I already told you, is expired carbon dioxide, or end-tidal carbon dioxide. And I told you it is surest to confirm intubation. When it is surest to confirm intubation, obviously it should be able to detect accidental extubation by chance tube get pulled out. There is extubation. Then what you expect to capnography? When the tube is not in trachea, from where CO2 will come out, which you can measure. So obviously the value will become zero. Expired value of CO2 will become zero, and graph, there will be no graph. So graph will be having the flat line. So if you see zero CO2 or graph become flat line, means your tube has come out. There has occurred accidental extubation. So it is CO2 becoming zero. I told you the most common condition is extubation. Then if there is apnea, means there is no ventilation, means no CO2. So again, it will become zero. or tube get disconnected. If the tube get disconnected from circuit, from where how your CO2 will reach the circuit and reach the monitor. So again it will become zero, because this is also dangerous. If tube is disconnected from circuit, means patient is not getting ventilated. Or if tube get completely obstructed. If endotracheal tube is completely obstructed, then how CO2 will come out of the endotracheal tube? So again that can kill the patient. So all these conditions, extubation, apnea, disconnection, complete obstruction, can kill the patient, can cause hypoxic brain damage. So these conditions are detected within seconds. You can see graph was coming and suddenly you see graph become flat line. Means either tube has been extubated or patient ventilator is not working, means patient is gone in apnea, or tube has been disconnected or has been completely obstructed. So you have to immediately intervene. So capnography is very sensitive, and in fact it has saved hundreds and thousands of the life of the patients. So this is all about, you can say, before starting anesthesia, how to give anesthesia, equipment choose for ventilation, equipment for giving anesthesia, how we do pre-operative assessment, what are the monitoring we should use during anesthesia, what fluid we are going to use. Now, after all this background, now let's come to the proper anesthesia part. So anesthesia can be general anesthesia, full anesthesia, or we can block one region of the body, that is regional anesthesia. So first we'll discuss the general anesthesia. So how to do general anesthesia? Just see, first we do pre-oxygenation with 100% oxygen for 3 minutes. And why we are doing that? So that nitrogen present in lungs is replaced with oxygen. Now whole of the lungs is filled with oxygen. Means we have increased the oxygen reserve of the body. Once pre-oxygenation is finished, induction is done with IV agents. And why we prefer IV agents? Because they are ultra fast acting. Induction means making the patient to become unconscious. So we want that patient should become unconscious very fast. So we are using intravenous agents. Then once the patient become unconscious, obviously now we have to secure our airway. And to secure airway means we have to intubate the patient. And for intubating the patient, you can only intubate if patient's muscles are relaxed, laryngeal, pharyngeal, oral, all muscles are relaxed. So we have to give muscle relaxation. Muscle relaxant most preferred is succinylcholine for intubation. Why? Because succinylcholine is very fast acting. It will produce relaxation within 30 seconds. So airway, laryngeal, pharyngeal muscles get relaxed and you can intubate the patient. Now after intubation, anesthesia is usually maintained with 75% nitrous oxide, 25% oxygen, and one of the inhalational agent, halothane, isoprudine, whatever you are using. So 75% nitrous oxide, 25% oxygen, and one of the inhalational agent, whichever is available, you can choose. Now, relaxation is not only required for intubation, relaxation is required for surgery. If patient muscles are not relaxed, how surgeon will do the surgery? So for achieving surgical relaxation, we have to use a long acting type of muscle relaxant, and that is non-depolarizing type of muscle relaxant. Then at the end of surgery, you have to reverse the effect of this non-depolarizer by giving neostigmine, and then patient is finally extubated. So that is how we do what we do in general anesthesia. So induction with IV agents, then intubation after giving dexamethasone, then throughout the surgery, anesthesia will be maintained on nitrous oxide, 75% oxygen, 25% and volatile agent and non-depolarizer muscle relaxant. Then at the end of surgery, we have to reverse the effect of non-depolarizer by giving neostigmine, and then patient is extubated. So in the same sequence, now we are going to discuss these agents. Intravenous agents. As I told you, they are used for induction. Intravenous agent, thiopentone. Nowadays, it is not used. It has been replaced by propofol. Why? I will tell you. Previously, it was used. So thiopentone, what you can remember, 2, 3 important points is that it has got very alkaline pH, highly alkaline pH, 10.4. And I'll tell you, it has got significance also. And all IV agents, not only thiopentone, actually they are metabolized by redistribution. Redistribution means when you give IV, drug first will go to the area with high vascularity like brain, and within 10 to 15 minutes it will leave the brain to reach the lower perfused areas like muscle or fat. So that is why we cannot use them for maintenance, because they will produce unconsciousness very fast, but only for say 10 minutes or so till they are in the brain and then they leave. So by that time you have to maintain anesthesia with inhalational agents, that is nitrous oxide, oxygen, and uh, volatile agent given through endotracheal tube through machine. Then another important property of thiopentone that you all must be knowing, must have read in your pharmacology, that it is the anticonvulsant of last choice. If epilepsy not controlled by any drug, is finally controlled with thiopentone. Then it is cerebroprotective. Why? Because it decreases the metabolic rate of the brain. So decreased metabolic rate means it can protect the brain. However, one complication of thiopentone that you should know, that if by chance accidentally it injected into artery, and this usually happens when it is given in antecubital fossa, because antecubital fossa, you know, they are close by artery. So by chance accidentally if you inject, what will happen? Because of its alkaline pH, it will get precipitated, and this precipitated thiopentone can cause endothelial injury. And when you know that there is endothelial injury, artery will go in spasm, and limb distal to the spasm become at risk of gangrene. And there has been case reports of gangrene in the past when thiopentone was injected in antecubital fossa. So obviously you have to give some of a vasodilator as a treatment, and the most preferred vasodilator is papaverine, because this thiopentone, because of precipitation, has called vasospasm. So we have to give vasodilator. Although any of the available vasodilator you can use, however, the most preferred vasodilator is papaverine, given at that point intraarterially where you have inject thiopentone. Propofol is most commonly used. Nowadays, most commonly used IV agent for induction is propofol. So propofol is prepared in soybean oil. Prepared in soybean oil. So it's an oil-based preparation, and you know that all oil-based preparations, they causes pain when you inject them. So that is why propofol, because of its oil-based preparation, is actually painful. Then it contains egg lecithin, and egg, you know, is a very good source for bacterial growth. So there are chances of bacterial contamination with propofol. Therefore, propofol, while once opened, you have to use within 6 hours. Otherwise, there can be chances of bacterial contamination. So once you have opened the propofol vial, you have to use within 6 hours, or after 6 hours you have to discard it. Otherwise, there are chances of bacterial contamination because it contains egg lecithin. Half-life 2 to 3 hours. Actually, this is the single most important reason for which propofol is actually preferred over thiopentone. Thiopentone half-life actually was very long, 10 hours. So we don't want any drug to be present in body for 10 hours. So therefore, that is the reason that which leads to obsolescence of thiopentone and replacement with propofol because of its shorter half-life. Then another unique property of propofol is that it is antiemetic and very strong antiemetic actually. It is even better than you can say ondansetron, very strong antiemetic. So this is also a unique property. So basically, I told you it is the IV agent of choice for induction routinely also, and as well as for daycare surgery, because daycare surgery, obviously our aim is to discharge the patient same day. So therefore we want drug with a shorter half-life, and I told you major advantage of propofol is its shorter half-life. So it is preferred also as an IV agent for daycare surgeries. Other agents, so most often, almost always, you can say 99% you will be seeing that patients are being induced with propofol. Other agents have specific indications like etomidate. Etomidate is most cardiac stable. Cardiac stable means obviously it will be the IV agent of choice for cardiac patient. So if a cardiac patient come for surgery, obviously we will choose a cardiac stable IV agent. So that is etomidate. However, in spite of being cardiac stable, we are not using it routinely because of the possibility of adrenocortical suppression. It can cause adrenal suppression, and this limits its use only for cardiac patients, not as routine. Benzodiazepines. Benzodiazepines basically are used in anesthesia for two purposes: for anxiolysis and secondly to produce amnesia, because you all know that benzodiazepines they produces amnesia. And among the benzodiazepines in intraoperative period, if you ask, we are actually only and only using midazolam. The reason being is again its shorter half-life. So because of the shorter half-life, benzodiazepine that is used in intraoperative period is only midazolam. Ketamine. Ketamine, you all know, produces dissociative anesthesia. Dissociative anesthesia means patient get dissociated from himself as well as surroundings. So dissociative, patient get dissociated. So what are the advantages of ketamine, or what are the specific indications for ketamine? It is the IV agent of choice for shock. Why? Because actually it stimulates sympathetic system. So stimulation of sympathetic system means will increase BP. So therefore it is the IV induction agent of choice for shock patients. Then it is preferred for full stomach patients. Why? Because it maximally preserve airway reflexes. So preserve airway reflexes means minimum chances of aspiration. So making it as an IV agent of choice for full stomach patients. And then it is a very, very potent bronchodilator, making it as an IV agent of choice for active asthma patients. It's a very potent bronchodilator. It is such a potent bronchodilator. In fact, it can be used even for the treatment of refractory status asthmaticus. So if asthma is not responding to any drug, you can try ketamine. Such a potent bronchodilator, very potent bronchodilator, and we are using very commonly in routine for refractory status asthmaticus ketamine. Very strong bronchodilator. However, the disadvantage for which its use is only limited to specific conditions is its vivid reactions. These vivid reactions can manifest in any form, like vivid dreaming, delirium. However, most commonly these vivid reactions they present as hallucinations. And to decrease these vivid reactions and these uh, hallucinations, the treatment of choice is benzodiazepines. And benzodiazepine, I told you, nowadays most commonly uses midazolam or any other benzodiazepines. So I will say rather benzodiazepines, whatever available. But now mostly available is midazolam, so I can say midazolam. Second disadvantage, ketamine can increase all pressures: intraocular pressure, intracranial pressure, and intragastric pressure. So all pressures, intraocular pressure, intragastric pressure, or intracranial pressures are increased with ketamine. Opioids. Obviously, the use of opioids in anesthesia is for analgesia. Analgesia. Opioids are analgesics. And the most important side effect of opioids you very well know is respiratory depression. The most common cause of death in a opioid poisoning is respiratory depression. Second, they can cause muscle rigidity. And sometimes this muscle rigidity is so severe in thoracic muscle that it is called as wooden chest syndrome. Means chest has become so stiff like wood, wooden chest syndrome. And maximum muscle rigidity, all opioids they can cause muscle rigidity. but maximum muscle rigidity has been seen with L-fentanyl. L-fentanyl. Then one more group of the drugs which are being used in anesthesia are alpha 2 agonist. And alpha 2 agonists, they produce sedation. They are sympatholysis. So therefore, they are used to produce sedation as well as adjuvant in anesthesia. So anesthesia, if they're producing sedation, anxiolysis, we will prefer them. So they are used as an adjuvant to anesthesia and to produce sedation. And for that reason, clonidine had been used for years, but clonidine now become obsolete because of its side effects like hypotension, bradycardia, and a new alpha 2 agonist that has recently been launched and freely available now is dexmedetomidine. So dexmedetomidine is a newer alpha 2 agonist which is used commonly now. And so just simply if they ask what is dexmedetomidine, so it is an alpha 2 agonist which is used as an adjuvant and to produce sedation, and it is preferred over clonidine because it has lesser side effects as compared to clonidine. So IV agents, I told you, we have used for induction, but they are metabolized by redistribution. So their effect from brain will finish in 10 minutes or so. So we have to maintain now anesthesia with volatile agents, inhalation agents. So inhalation agents, inhalation is given through lungs, inhalation route. So they are used for maintenance of anesthesia. So they are used for maintenance of anesthesia. Now, there are many properties, but of course, it's not possible for you and not required for you also to go in details. Two important properties that you should know. One is the potency, how much an agent is potent. And potency is denoted by MAC, that is minimum alveolar concentration. So minimum alveolar concentration means what is the minimum concentration required to produce unconsciousness or effect. So minimum alveolar concentration represents the potency. It's an indicator of potency. So the only thing you have to remember is most potent and least potent. That's it. Forget about everything. So most potent among the volatile agents is halothane and least potent is nitrous oxide. So before that, I'll tell you actually how to, there is no standard classification, but from your understanding point of view, inhalation agent you can say are gaseous, and we are going to discuss the agents which are used nowadays or volatile agents. So gaseous agents which we are using is nitrous oxide, and second, I will not say used, okay, forget about that. Nitrous oxide. Volatile agents which are in practice nowadays, there are four. They are halothane, isoflurane, desflurane, and sevoflurane. So these are the four volatile agents which are being used, and one gaseous agent that is used is nitrous oxide. Second, so most potent I told you is halothane among these, and the least potent is nitrous oxide. That's it. You have to remember most and least potent. Most potent halothane and least potent inhalation agent is nitrous oxide. Second property is blood gas coefficient, blood gas solubility. So blood gas solubility or blood gas coefficient is indicator of induction time and recovery time. Again, we will not go in details. So blood gas coefficient or blood gas indicator is solubility is the indicator of induction and recovery. Again, you have to remember which is the fastest induction and which is slowest. So fastest induction is with xenon. Actually, xenon is another gas. It is not yet available freely for use, but it is almost, you can say, ready for use. So you won't say agent available freely, but yes, ready to use. So most fastest induction is with xenon and the slowest induction is with halothane. And there is actually no other method to remember other than mugging up. So fastest induction and recovery is xenon, and slowest induction and recovery is with halothane. And potency wise, I told you, least potent is nitrous oxide and most potent is halothane. So there is no actually mnemonic also. So you have to just mug it up. Now coming to important property of each of these agent, nitrous oxide. One of the very important property, or you can say disadvantage of nitrous oxide, is that it is 35 times more soluble than air. What do you mean by that? That if there is any air present in the body, particularly if there is air present in a closed space, like say pleural cavity. So what will happen? For 1 mole of air removed will be replaced with 35 molecules of nitrous oxide. So imagine how fast a small pneumothorax will get converted into tension pneumothorax. So if there is any air in any of a closed space like pneumothorax, pneumomediastinum, pneumopericardium, obviously nitrous oxide is absolutely contraindicated. So air in any of a closed space, pneumothorax, pneumomediastinum, pneumoencephalum, pneumopericardium, nitrous oxide is absolutely contraindicated. Then another disadvantage of nitrous oxide is ozone depletion. Actually, all anesthetic agents can cause ozone depletion, but it is more important for nitrous oxide because here we are using higher concentration, 75%. And considering these problem of ozone depletion and expansion of cavities, they actually have studied xenon because xenon has many advantages over nitrous oxide. It doesn't have any side effect like nitrous oxide. Ozone depletion and expansion of cavities, those side effects are not seen with xenon. But problem is only limiting factor why xenon is still not getting popular is cost. Very expensive. And this is the reason that xenon actually is not becoming popular. Halothane. Halothane nowadays is less commonly used in Western countries, but in India we are still using because it is still comparatively cheap. So both of the property of halothane we already have discussed that among the agents which we are using nowadays, it is most potent volatile agent and it has got slowest recovery, slowest induction and slowest recovery. Then another unique property, we are going to discuss important properties of these agents that halothane can sensitize myocardium to catecholamines. So halothane can sensitize myocardium to adrenaline or catecholamines. So means in the presence of adrenaline, there are increased chances of arrhythmias. Then halothane can cause hepatitis. Very well known entity seen with halothane is halothane hepatitis. And there were a lot of theories that why halothane is causing hepatotoxicity, hepatitis, and now it is proven that it has got autoimmune mechanism. Means there is some product of halothane which is antigenic and produces antibodies leading to antigen antibody mediated hepatitis. So it is autoimmune hepatitis. Isoflurane. Isoflurane, what you can remember is that it has got irritating induction. Means it cannot be utilized for induction because its induction is irritating. But it is most cardiac stable, making it as a inhalational agent of choice for cardiac patients. Just if I ask you, what is the IV agent of choice for cardiac patients? Etomidate. And inhalation agent of choice for cardiac patients is isoflurane. Then it was actually inhalation agent of choice for all cardiac patients except MI. Because MI, it was believed that it causes coronary steel. But recently it has been proven that it does not causes coronary steel. So very important recent advancement on which again you can expect the question. So for decades we were not using isoflurane for MI patients because it was causing coronary steel. Coronary steel means diversion of fluid from ischemic area to non-ischemic areas. So that is dangerous for MI patients. But it is proven that it does not causes coronary steel. Desflurane, like isoflurane, it also has got irritating induction. And already we have discussed that with desiccated soda lime, already we discussed before, with the desiccated soda lime, means dry soda lime, it can produce carbon monoxide. It can produce carbon monoxide. Then advantage of desflurane is minimal metabolism. Metabolism is less than 0.1%, means almost negligible metabolism. And so the advantage is then on metabolism, these inhalation agent they produces fluoride. So it will not produce fluoride. And you all know that fluoride can cause nephrotoxicity. So it does not produce fluoride, making it as a inhalational agent of choice for renal patients because it does not produce fluoride. Sevoflurane. Sevoflurane also commonly used and it is the inhalational agent of choice. IUC is nothing. This is the inhalational agent of choice for pediatric induction. Why? Because among all inhalation agents, it is smoothest. But that doesn't mean that we prefer inhalation agents for induction. I told you, preferred method of induction is always IV. But the problem in children is that children will not allow us to put IV lines. So first we have to directly induce them by inhalation induction. And once they fall asleep, then we are putting IV cannulas. So in that case, only we have to use inhalation agent and inhalation agent of choice in that case would be sevoflurane because it has got smoothest induction. Then it is an excellent bronchodilator, making it as an inhalational agent of choice for asthma patients. Asthma patients. And then all these inhalation agents, they increases the intraocular pressure. But minimum increase is seen with sevoflurane, making it as an inhalational agent of choice for neurosurgery. And why I use green pan? Because in books you may find that inhalation agent of choice given is isoflurane. Previously it was true, isoflurane, but now they found that increase in intraocular pressure seen with sevoflurane is lesser than isoflurane, making it as an inhalation agent of choice for neurosurgical patients. Then muscle relaxants. So muscle relaxants, I told you we use for two purposes, to produce relaxation for intubation and secondly to produce relaxation for surgery. What happened? There is some problem. What happened? Where is slides of muscle relaxant gone? Some slides are missing. So just give me 2 minutes break. I just need to see how what happened to the slides where they went. Just little rearranged. Okay, fine. Okay. No. Some slides, I don't know how they got missed. Just give me 2 minutes, I'll just to see how they went. Okay, no problem. I think we can add a few slides, no problem. So, I don't know about muscle relaxants, they have been classified as depolarizers and non-depolarizers. Depolarizers and non-depolarizers. So, depolarizer that we are using is succinylcholine, also called as succinylcholine. Succinylcholine and succinylcholine is the muscle relaxant of choice for intubation. Muscle accent of choice for intubation. And why it is preferred for intubation? Because its onset is very fast, within 20 to 30 seconds. And secondly, duration is also very short, at less than 10 minutes. And why it has short duration? Because it is metabolized by pseudo cholinesterase. So it is metabolized rapidly by plasma pseudocholinesterase. So therefore, its duration is also slow. So because of the short duration and because of faster onset, succinylcholine is used in anesthesia for intubation. Intubation. Side effects or the major disadvantage of succinylcholine, most important side effect of succinylcholine is hyperkalemia. And why? Actually, succinylcholine depolarizer means what? How it will act? It will act exactly like acetylcholine, binds to the same receptors, producing muscle contraction in all body muscles, which you can see as fasciculations. And continuous persistent depolarization will make the membrane to become refractory for a transient period. That period is the period of relaxation. So it produces muscle contractions. So muscle contractions will release potassium. So that is why it can cause hyperkalemia. So the major side effect of succinylcholine is hyperkalemia. Then, like ketamine, it can also increase all pressures: intraocular pressure, intragastric pressure, and intracranial pressure. All pressures are increased with succinylcholine, like ketamine. And secondly, it is the most commonly drugged to trigger malignant hyperthermia that we'll discuss later. So, it is the most commonly implicated drug to trigger malignant hyperthermia. Then non-depolarizers. So the non-depolarizers, they are used for maintenance of surgical relaxation because they are long acting and they are competitive antagonist. Means they bind to the same receptor site at which acetylcholine binds, preventing acetylcholine to bind to that receptor site. So competitive antagonism. And among non-depolarizers which are used, vicuronium, most important thing about vicuronium you can remember is that it is most cardiac stable. Most cardiac stable. Then atracurium. Atracurium, the unique feature of atracurium is that it is spontaneously degraded. Spontaneous degradation. So you can say atracurium and one of its derivative, that is cis-atracurium. So cis-atracurium actually has lesser side effects compared to atracurium. So atracurium, if you have to choose between atracurium and cis-atracurium, always you have to choose cis-atracurium because it is a newer drug and it definitely has lesser side effects as compared to atracurium. So the unique feature of atracurium and cis-atracurium is that they are spontaneously degraded, automatically degraded, and this spontaneous degradation is called as Hoffman degradation. So Hoffman degradation is a spontaneous degradation. So spontaneous degradation means automatically it get metabolized. So no risk of accumulation. No risk of accumulation means making it as a muscle relaxant of choice for renal patients. Renal failure patients, we always have a risk of accumulation of the drug. But this drug is automatically metabolized, so there is no risk. And also the muscle relaxant of choice for liver failure because it is not dependent on liver for its metabolism, automatically degraded, spontaneously degraded. So atracurium and cis-atracurium are the muscle relaxant of choice for hepatic failure and renal failure. And among these, by chance, if you get a question where both cis-atracurium and atracurium have been given, then you have to choose cis-atracurium. The one more depolarizer which you can remember is rocuronium. Rocuronium is a derivative of vicuronium. Now the disadvantage or you can say advantage of rocuronium or other muscle relaxant is that comparatively it has fast onset, making it as a non-depolarizer of choice for intubation. Muscle relaxant of choice for intubation is succinylcholine, I told you. But if there is some condition where we cannot use succinylcholine, like say patient is already having hyperkalemia, you cannot use, or patient already have increased intracranial pressure, neurosurgery, you cannot use, or glaucoma, you cannot use. So in that case, we have to intubate the patient with non-depolarizer, and non-depolarizer of choice for intubation is a rocuronium. So don't get confused. If they ask you muscle relaxant of choice for intubation, it is still succinylcholine. But by chance, specifically if they ask you non-deposit of choice for intubation, then it is rocuronium. Then mivacurium. Mivacurium among the muscle relaxant has shortest acting non-depolarizer. Shortest acting non-depolarizer, making it as a muscle relaxant of choice for daycare surgeries. Daycare surgeries, you know that muscle action, any drug should be short acting. So mivacurium is short acting, making it as a muscle accent of choice for daycare surgery. IV agent of choice for daycare surgery, already we have seen propofol. Now the effect of non-depolarizer has to be reversed. If you don't want active form of muscle action, otherwise it can be life threatening. So the effect has to be reversed. And for reversal, we can use cholinesterase inhibitors, that is neostigmine. And how neostigmine acts, you already know that neostigmine cholinesterase inhibitors, it will uh, inhibit cholinesterase and that will prevent degradation of acetylcholine. So there is more acetylcholine available at neuromuscular junction to compete with non-depolarizers. But the problem is that increased acetylcholine will also have muscarinic side effects like bradycardia, bronchospasm. So to combat these muscarinic side effects, we have to use one of an anti-muscarinic drug, that is glycopyrrolate. So when we say actually reversal, that does mean neostigmine along with the glycopyrrolate. And glycopylate, I told you, is given to prevent the muscarinic side effects. Another reversal agents which can be used are gamma cyclodextrins. Gamma cyclodextrins is another group of the reversal agents which directly bind to muscle relaxin. Neostigmine act indirectly by increasing acetylcholine. But these gamma cyclodextrins, they just act like magnet. They will just bind to the muscle relaxin and deactivate. So gamma cyclodextrins available in the brand name Sugammadex. Available in the brand name Sugammadex, they directly bind to muscle action and reverse them. Now, some of the common complications of general anesthesia. Aspiration. Aspiration, they say, is a preventable complication. Preventable complication, and although not always possible to prevent, but yes, largely it's a preventable complication. And the best method to prevent aspiration is that keep the patient fasting. So fasting is the single most important method to prevent aspiration. And your fasting guidelines is solid food. Patient has to have fasting of 6 hours. Fatty non-vegetarian meal fasting has to be 8 hours. For clear fluids means water or plain juices without pulp or tea or coffee without milk. That is clear fluids, 2 hours. While if the baby is on breast milk, then fasting of 4 hours is required. So this fasting is must to prevent aspiration. Solid food, 6 hours. Fatty non-vegetarian meal, 8 hours. Clear fluids, 2 hours. And breast milk fasting of 4 hours is required. But there are some situations where you will not have fasting patient. Like patient is coming for emergency surgery and patient is not fasting, you have to do the surgery. So if you find that kind of patient, so what should be the anesthetic management of the patient who is at high risk of aspiration? So high risk of aspiration, if the patient is given GA, the kind of technique that we follow is called a rapid sequence induction. So in rapid sequence induction, the two important difference from normal is that bag and mask ventilation is absolutely contraindicated, because I told you the biggest disadvantage of mask ventilation is increased risk of aspiration. So in rapid sequence induction, the two important differences is that bag and mask ventilation is absolutely contraindicated. And secondly, as soon as patient fall asleep, assistant applies the cricoid pressure. And this is called as Salix maneuver. So what the assistant is doing by the cricoid pressure, he or she is pushing the cricoid posteriorly so that esophagus is compressed between his fingers and vertebral column. So esophagus get compressed means patient will not be able to aspirate. So these are the two important things when you are giving anesthesia, general anesthesia for a patient who are at high risk of aspiration. No bag and mask ventilation and Salix maneuver. Then CNS complications can be convulsions, and the regions of convulsions may be hypoxia or anesthetic drugs which can cause convulsions. Methoxytone we did not discuss because it is not used nowadays, so we did not discuss. In fact, also propofol can also cause convulsions, but rarely. Similarly, etomidate can also cause convulsions, but rarely. One volatile agent, inhalation agent which can cause convulsions is enflurane, but enflurane again we did not discuss because that is not used in present day. Among the agents of the present day, yes, sevoflurane has found to cause convulsions, but that is again very rare. And one more region of convulsion during anesthesia that we see is local anesthetic toxicity can also cause convulsion. So these are the common regions of convulsion that you encounter in anesthesia practice. GI complications can be nausea and vomiting. And nausea vomiting is not only the most common GI complication. In fact, nausea vomiting is the most common post-operative complication of general anesthesia. And why I'm using green pen? Because maybe in books you will find most common post-op complication mentioned is pain. Previously, pain used to be believed, but in current day practice, as per the recent studies, most common post-op complication of general anesthesia is nausea and vomiting. Anaphylaxis. Any drug in perioperative period can cause anaphylaxis, but the most common cause of anaphylaxis is antibiotics. And again, why I'm using green pen? Because in books you will find most common cause of anaphylactic reactions mentioned is muscle relaxants. And that was true because previously there was a French study which was proving that the most common cause of anaphylaxis is antibiotics. There is a recent British study which shows that the most common cause of anaphylaxis is antibiotics, not muscle relaxants. Thermal complications can be hypothermia or can be hyperthermia. And one hyperthermia related complications which is very dangerous is malignant hyperthermia. And for malignant hyperthermia, the most commonly implicated drug is suxamethonium. So suxamethonium is most commonly implicated drug. Then other than suxamethonium, all volatile agents, they can also trigger malignant hyperthermia. However, among volatile agents, most commonly implicated volatile agent is halothane. Fine. So if they ask you most commonly implicated drug, it is suxamethonium. But if they ask you most commonly implicated volatile agent, then it is halothane. So sometimes very trickily they ask this question and you may end up in doing wrong answer in spite of knowing the answer. And the treatment of malignant hyperthermia you all know is dentrolene sodium. Dentrolene sodium. Then after general anesthesia, now regional anesthesia. Regional anesthesia means we are going to block one of the region of the body. So these regional anesthesia, before starting regional anesthesia, let's say important property of local anesthetics. Now sequence of nerve fibers, most controversial, and I will, and the reason for most controversial is actually when we talk of regional anesthesia, it can be peripheral nerve blocks or central neuraxial blocks. Central neuraxial blocks means spinal and epidural. Means given along the central neuraxis. Spinal epidural are central neuraxial block. All other blocks are peripheral nerve blocks. And this is the region that it actually has caused controversy. There are many factors which affect the sensitivity of a nerve fiber to local anesthetics. Many. So considering all these factors together, for peripheral nerve blocks, it has been seen that first to be blocked are A fibers, then B, and then C. While for central neuraxial blocks, first to be blocked are B fibers, then A, and then C. And this is the reason for controversy. And if they don't mention anything, then consider that they are asking for peripheral nerve blocks and the sequence of blockade will be ABC. While specifically if they give you central neuraxial blocks, then the sequence of blockade will be first to be blocked is B, then A, and then C. Got it? And the recovery is in reverse order. Means for peripheral nerve block, first to recovery C, then B, and then C. While for central neuraxial block, first to recovery C, then A, and then B, reverse order. Similarly, if they ask you in functional terms, again the reason for controversy is same. Because for peripheral nerve blocks, first to be blocked is motor, then sensory, and then autonomic. While for central neuraxial blocks, first to be blocked is autonomic, then sensory, and then motor. And recovery is again in reverse order. Again, that is a region that causes controversy. For peripheral nerve blocks, motor, sensory, autonomic. For central neuraxial blocks, autonomic, sensory, motor. And if nothing mentioned, then consider it as peripheral nerve blocks. Now I hope that you will not go wrong with this question and very frequently asked. Toxicity. The main systems which are involved in local anesthetic toxicity are CNS and CVS. And CNS is more sensitive. So therefore, CNS is blocked earlier than cardiovascular system. So CNS is more sensitive than cardiovascular system. Now, another very important thing that you should know that local anesthetics with adrenaline must not be used for ring block of finger, toes, penis, or pinna because these structure have end arteries, and if you use adrenaline, there can be gangrene. So, if you are using ring block of finger, toes, penis, or pinna, you have to use lignocaine plain without adrenaline. Now, coming to individual agents, only important properties we are going to discuss. Prilocaine. Only thing about prilocaine which you can remember is that prilocaine can cause methemoglobinemia. However, this methemoglobinemia is only seen at very high doses, not at normally used clinical doses. Lignocaine, obviously most commonly used local anesthetic, and the duration of lignocaine without adrenaline. It's available with adrenaline and without adrenaline. Duration without adrenaline is around 45 to 60 minutes. But if you add adrenaline, imagine the systemic absorption is reduced, more drug is available at local place, and duration can be increased almost 2 to 3 times. From 45 to 60 minutes to duration can be increased to 2 to 3 hours. Second thing, you have to know maximum safe doses because if you know the maximum safe doses, then only you can prevent toxicity. Maximum safe doses without adrenaline is 4.5 milligram per kg. But if you add adrenaline, obviously systemic absorption is reduced. So we can give more drugs. And dose from 4.5 milligram per kg can be increased to 7 milligram per kg. So without adrenaline, 4.5 with adrenaline 7 milligram. Similarly, duration without adrenaline 45 to 60 minutes and with adrenaline 2 to 3 hours. So adding adrenaline have two advantages. It increases the duration and it increases the doses also. Second local anesthetic which is commonly used is bupivacaine. Duration of bupivacaine is 2 to 3 hours. And when we say bupivacaine, actually bupivacaine is not available with adrenaline. So means plain bupivacaine. Bupivacaine 2 to 3 hours and maximum safe dose is 2 milligram per kg. 2 milligram per kg. Then bupivacaine can be used for painless labor and post-operative analgesia. Actually, we are using local anesthetics frequently for painless labor and post-operative analgesia through epidural route. Bupivacaine is most preferred because at lower doses, it actually only produces sensory effect. So there is no risk of motor block at lower doses. So therefore, we are preferring bupivacaine. Then one thing about bupivacaine that you must remember is its cardiotoxicity. Cardiotoxicity can actually manifest in any form ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia, and ventricular tachycardia is not so infrequent with bupivacaine. And drug of choice for the treatment of ventricular tachycardia is amiodarone. And why I'm using green pen? Because previously drug of choice for bupivacaine induced ventricular tachycardia used to be bretaglium. But recently it has found that amiodarone is more effective than bretaglium. Then antidote for cardiotoxicity or as such toxicity of bupivacaine is intralipid. Wow, how intralipid is going to block the active form of bupivacaine. Then considering this cardiotoxicity, now they have some isomers of bupivacaine, that is levobupivacaine and ropivacaine. So levobupivacaine and ropivacaine are the S isomers of bupivacaine, and their main advantage is obviously less cardiotoxicity. So obviously wherever possible, we will be preferring ropivacaine. If ropivacaine not available, we can use levobupivacaine because they are less cardiotoxic as compared to bupivacaine. Now, peripheral nerve blocks. Among the peripheral nerve blocks, most commonly used is brachial plexus block. And brachial plexus is blocked for upper limb surgery, obviously. And brachial plexus we can block at four sites between middle and interscalene, supraclavicular level, infraclavicular level, and axillary level. So interscalene level between anteromedial scale line, the advantage is ulnar nerve is spared. Ulnar spared means it cannot be utilized for hand surgeries. Supraclavicular is actually most common use approach. Just above the midpoint of clavicle, we are blocking this brachial plexus. So supraclavicular, but supraclavicular, the most bothersome complication that we have to deal with can be pneumothorax. You can puncture the pleura here, causing pneumothorax. Infraclavicular failure rate is high. So generally people are not preferring, obviously failure rate is high, will not prefer. Axillary, in the axilla we are blocking brachial plexus. The disadvantage is musculocutaneous nerve is spared. Musculocutaneous spared means it cannot be used for arm surgeries. Then one more block of peripheral nerve block which has been frequently asked from you is the stellate ganglion block. And stellate ganglion block, you know, is given for reflex sympathetic dystrophies. And reflex sympathetic dystrophies, all you know, is a group of diseases mediated because of sympathetic overactivity, and it includes many diseases. Must have read in your surgery, Raynaud phenomena, Raynaud disease, pseudocostoid dystrophy, phantom limb. So since these are happening because of the sympathetic overstimulation, so we have to give sympathetic block. And sympathetic supply of the upper limb is mediated through stellate ganglion. So where we are blocking stellate ganglion? At the Shagneck tubercle, which is the tubercle of the C6. Tubercle of the transverse process of C6 is called as Shagneck tubercle. So at that level, we have to give the stellate ganglion block. And how do you know your block is successful? If patient is exhibiting the signs of Horner syndrome. And the components of Horner syndrome you already know: ptosis, meiosis, anhidrosis, and ophthalmos. So if the patient is exhibiting signs of Horner syndrome, that means your stellate block has been successfully blocked. Then central axle blocks. Central axle blocks, I told you, means spinal and epidural. Means given along the central neuraxis. Now, before that, some of the very important anatomical landmarks, applied anatomy that you should know is one is the extension of spinal cord. You know, during intrauterine life, spinal cord occupies whole of the vertebral column. Thereafter, the growth of vertebral column is more as compared to spinal cord. So spinal cord start ascending, and in infants, it lies at the lower border of L3. Thereafter also the growth of vertebral column is more, so it ascends further, and in adults it lies at the lower border of L1. So the clinical significance of this is, like if I ask you to do lumbar puncture in a child, infant, then you must use a space below L34, that is L45 or L5S1, because it is up to the lower border of L3. So if you are inserting your needle and your needle become cephalate, you can cause direct injury to spinal cord. Similarly, in adults, you should never use any space above L1, L2 or L1, L2 also in fact. Then what are the structures which are encountered when you are giving spinal anesthesia? So you are obviously entering from posterior side to anterior. So first to encounter will be skin, very frequently asked in your exams. FMG, I will say one of the most favorite question. At least 3-4 times they have asked this structures you are going to encounter in another way or this way, that way. So first to encounter is skin. So it's very important from your FMG point of view. In fact, skin, then you will be piercing subcutaneous tissue, then supraspinous ligament, which connect the tip of spinous processes, then interspinous, as the name suggests, means between the spinous processes, then ligamentum flavum, also called as yellow ligamentum, and after that you are piercing the dura, and after dura arachnoid, and you know that CSF is present here between arachnoid and pia. So spinal is given here, and then that is why you know that spinal is also called as subarachnoid block. Drugs used, lignocaine or bupivacaine. However, lignocaine is not used nowadays because it can cause cauda syndrome. 5% lignocaine was used before, but it caused cauda syndrome, so people stopped using. So nowadays we are only and only using bupivacaine, and this bupivacaine is actually this bupivacaine we are using is hyperbaric. Hyperbaric means specific gravity is more than that of CSF, so drug will always try to settle down. Hyperbaric. Systemic effects. The most prominent effect of spinal anesthesia is hypotension. And the reason is we are causing lumbar sympathetic block. So lumbar sympathetic block will lead to venodilatation, venous pooling, decreased venous return, decreased cardiac output and hypotension. Then there can be bradycardia. Normally, with hypotension, there is tachycardia, but in spinal, you have caused sympathetic block. So this sympathetic block will lead to cranial parasympathetic codominance that can cause bradycardia. Or if the level becomes high, means drug reaches say so high to block intercostal, so high to block even your this cervical fibers, phrenic nerve, or can reach even brain. So that can cause high spinal or total spinal. Total spinal means drug has even reached the brain. So that can be another complication, dangerous complication. Post-operative complication. Nowadays, the most common post-operative complication is urinary retention. And why I'm using green pen? Because previously, most common post-op complication used to be post-spinal headache. But now the incidence of headache has reduced. So you can say the most common post-op complication is urinary retention. But if they ask you most common complication, so don't get confused. Most common complication is hypotension. Hypotension is virtually seen in almost all patients. So urinary retention is the most common post-operative complication. So this question can be little tricky and you may get it wrong. So be careful. Then post-spinal headache. Why post-spinal headache? So post-spinal headache is actually, as the name suggests, means spinal occurring, this headache occurring after spinal anesthesia. And why it happens? Because with your needle, you have made a hole in dura. Through that hole, there will be continuous seepage of CSF, and continuous seepage of CSF will decrease the ICT, and decrease in ICT will lead to shrinkage of brain and meninges. And when brain and meninges get stressed, vessels also get stressed. So basically, it is a low pressure and meningovascular headache. So low pressure meningovascular headache. Prevention, use fine gauge needles. Means if you use very fine gauge spine needle, obviously damage to dural fiber will be less. So loss of CSF will be less. So post-spinal headache will be less. Or there are two type of needles. Dura separating means they will just separate the dura. They will not cut the dural fibers. That because the tip is like pencil tip. So if you use pencil tip needles and fine gauge needles, the incidence of post-spinal headache can be drastically reduced. Epidural, the needle that is used for epidural is 2OS needle. This is the 2OS needle. And technique is loss of resistance. Loss of resistance means we are, as soon as you pierce the ligamentum flavum, there will be sudden loss of resistance so that you can very well feel. So epidural means outside the dura. Means drug is injected outside the dura. Means between dura and ligamentum flavum. Now, contraindications for central vessel blocks is a big list, but only the absolute contraindications that you must know and has been frequently asked. Raised ICT. Why? If you raised ICT, if you puncture the dura, there will be loss of CSF, sudden decrease in ICT, and sudden decrease in ICT can cause coning. And you know that this medullary herniation can cause immediate death of the patient. If the patient is suffering from some coagulopathy or anticoagulants, so obviously if there occur bleeding, that hematoma can become large, compress the spinal cord and can cause paraplegia. If the patient is refusing, you cannot give by force. Spinal causes hypotension. So if the patient is already suffering from severe hypovolemia, you cannot give spinal. If there is infection at local site, you cannot introduce infection from outside into meninges. So that's an absolute contraindication. Patient with severe fixed cardiac output lesions like aortic stenosis or mitral stenosis, they cannot increase their cardiac output there because uh, they have stenotic lesion, so they cannot treat their hypertension. So obviously, absolutely contraindicated. Now, specialty management. So this is all. See what all we have discussed. Just this is a summary. So let's see how much you are able to recall. Cardiac patients. See, if we can give regional anesthesia, it is safe. There is no contraindication for any kind of nerve block. Safe. If you are giving GA, then induction agent of choice for cardiac patient is etomidate. Why? Because most cardiac is stable. Maintenance agent of choice is isoflurane. Why? Because most cardiac is stable volatile agents. And muscle extent of choice for cardiac patients, vicuronium, because most cardiac stable. Respiratory system. Respiratory system, we want to avoid touching the chest, lungs. So therefore, we will always prefer regional anesthesia. If we can avoid GA, touching respiratory system, obviously anesthesia of choice, if they ask you, it will be regional. But all surgeries are not possible under regional. So if you are giving GA, then induction is propofol for controlled asthmatics. So when we say actually respiratory means it is say asthma or COPD. For control, it is propofol. However, if it is active asthma, I told you before, then we have to use ketamine. Maintenance, sevoflurane. Why? Maximum bronchodilation. Muscle laxant, you can use anyone. So forget why steroid. Any muscle laxant you can safely use. Hepatic patients, we have to avoid regional. Why? Because hepatic patient may be suffering from coagulopathy. And coagulopathy is a contraindication for regional anesthesia. So anesthesia of choice is GA. During GA induction, propofol. Why? Because short half-life. And for hepatic renal patient, we always prefer the drugs with a short half-life. So propofol. Maintenance, sevoflurane. Why? Because it minimally decreases the hepatic blood flow. Hepatic blood flow is minimally decreased with sevoflurane. And muscle laxant for hepatic patients, I told you cis atracurium. And if cis atracurium not available, then atracurium because of Hoffman degradation. Renal patients, again, renal patients, we cannot give fluid. When you cannot give fluid, you cannot treat hypotension. So you cannot give regional anesthesia. So obviously anesthesia of choice becomes general anesthesia. Induction, again, propofol, short duration. Maintenance, desflurane, I told you, because it does not produce fluoride. No fluoride. And muscle accent, again, cis atracurium or atracurium because of Hoffman degradation. So no risk of accumulation. Myasthenia patients, muscular dystrophy patients, or other word you can say neuromuscular disease patients, very frequently asked in exams. So myasthenia patients, muscular dystrophy patients, the problem is that they exhibit abnormal sensitivity to muscle laxants. So avoid muscle laxants means avoid GA, means anesthesia of choices regional, but that is not always possible. We have to give GA. If GA, then obviously induction propofol, short duration. Maintenance agent is desflurane, least effect on muscle laxant. Desflurane, muscle laxant. Again, we use, they have increased sensitivity to muscle laxants. So therefore, we have to use muscle laxant which does not have risk of accumulation, like mivacurium, short acting. no risk of accumulation. Cisatracurium, atracurium also have no risk of accumulation. And if it is muscular dystrophies, then saxamethonium is absolutely contraindicated. Not only that, in fact, giving saxamethonium to muscular dystrophies patients can turn out to be even a fatal event. Neurosurgical anesthesia, induction agent of choice is thiopentone. Why? I told you, because thiopentone is cerebroprotective. Maintenance, I told you already, sevoflurane, minimal increase in ICT. Muscle relaxant, we can use non-depolarizers, while saxamethonium should be avoided because it increases intraocular pressure. Obstetric patients, patient do come to us for cesarean section. For cesarean section, anesthesia of choice is spinal. Avoid GA. Why? Because the risk of GA is increased risk of aspiration. A pregnant patient is 8 times at higher risk of aspiration as compared to non-pregnant patients. So even if you are giving GA, treat her as a full stomach patient, and GA should be given under rapid sequence induction. Very high risk of aspiration. If there occur hypotension, then vasopressor of choice is phenylephrine. And I'm using green pen because previously ephedrine used to be preferred vasopressor for pregnant patients, but now phenylephrine has found to produce less vasoconstriction in uteroplacental circulation, so it is preferred over ephedrine. Now, another important thing for PIH patient, previously we were not giving spinal, but now spinal can be safely given. Not only so, you can say it is the anesthesia of choice for PIH patients. Why previously we were not giving spinal? Because PIH was uncontrolled hypertensive, so she can do it after spinal, she can develop more hypotension. But this is well manageable, so we can safely use spinal for PIH patients. Second is patient may be coming for painless labor. Second group. For painless labor, we are using epidural through lumbar epidural. And if that is not possible, then you can ask the patient to inhale Entonox, which I told you is 50% oxygen and 50% nitrous oxide. Pediatric anesthesia, obviously we have to give GA. And for GA induction, I told you always induction even in pediatric is IV preferred. This can be very tricky. First choice is always IV, whether adult or pediatric, ultra fast acting. But the problem I told you, many children are coming without IV lines. If they are coming without IV lines, then we have to go for inhalation induction. Because I saw one tricky question even in FMG. Induction agent of choice in pediatric, I think 2-3 years back, they asked. First choice they have given sevoflurane and last choice was propofol, and all students attempted sevoflurane and the question was wrong. They have asked induction agent of choice, a child I think was going some surgery, a 6-year-old child, some clinical situation was like that. So preferred method is always IV. If IV not accessible, then inhalation and inhalation. First choice is sevoflurane. If sevo not available, then you can use halothane. And isoflurane and desflurane, I told you, cannot be used because they have got irritating induction. If you can't remember all those details, forget, you can just remember first choice is sevoflurane. That should be more than enough, I think. No need to go in further details. Daycare surgery means we are discharging the patient same day. So if you are doing daycare surgery, we always prefer laryngeal mask airway over intubation because I told you intubation has complications and LMA provide good ventilation. So you can use laryngeal mask airway preferred. But whether you are putting LMA or endotracheal tube, that is not important. Important is drug selection. IV agent that you should choose is propofol. Opioid, if you are using, you have to choose remifentanil because you all know that remifentanil is also ultra short acting. Inhalation agent of choice preferred is sevoflurane. And muscle relaxant of choice is mivacurium. And benzodiazepine of choice is midazolam. So if you are going for daycare surgery, these are the drugs which you have to select. IV, propofol, opioid remifentanil, inhalational sevoflurane, muscle relaxant mivacurium, and benzodiazepine is midazolam. Laparoscopy. The ideal gas for inflation is argon because it is inert, no side effect. However, this argon is too expensive to afford. So therefore, most preferred gas or most commonly used, I will say, is carbon dioxide because it has got high diffusibility. Means wherever it goes, it get absorbed from that surface within 15 to 20 minutes. So CO2. Most important thing during laparoscopic surgeries is you have to watch intra-abdominal pressure and ensure that intra-abdominal pressure never go above 14 mmHg. Otherwise, that can compress IVC and can decrease the cardiac output significantly. If this pressure become 20, that can even cause cardiac arrest. So this is a very important thing you have to monitor during laparoscopic surgeries. Critical care, oxygen delivery device is very, very important. In last 1 or 2 years, 3 years, we have seen because of the COVID, this oxygen delivery devices has become very, very important. That how much should be the maximum flow you can use through this kind of oxygen delivery device, and what is the maximum output we are going to get. So this is nasal cannula. This is simple oxygen mask. This is oxygen mask with reservoir bag, and this is a Venturi mask with coming in different colors. Fine. So this is very important table. You must remember it very frequently. You can expect a question on this. With the nasal cannula, maximum flow you can use is 6 liter per minute, and that maximum FiO2 you are going to get is 0.4. FiO2 means maximum delivered oxygen. 0.4, or other words, you can say 40%. So if we are using nasal cannula, I've seen people using 10 liter, 15 liter with nasal cannula, they are wasting oxygen. At 6 liter, you get a maximum output of 40%. Simple oxygen mask at 10 liter is the maximum flow at which maximum output is 0.6, 60%. Oxygen mask with reservoir, you can use up to 15 liter, and at 15 liter you can get 0.8, that is 80%. And Venturi mask, again, maximum flow you can use is 15 liter, and maximum output you are going to get is 60%. So this is a very important table you must remember, very much expected question. Then you know that this non-invasive ventilation, normally we think if we are putting a patient on ventilator means mandatorily intubating, but that's not true. You can ventilate patient through non-invasive ventilation with the mask also. And why? There are many advantages, but the most important is decreased incidence of ventilator associated pneumonia, VAP. Intubation can increase the risk of pneumonia. But the disadvantage is patient can feel claustrophobic with this mask. Now, another very important thing that you must know is the lung protective strategy. And four components of lung protective strategy is low tidal volume. Most important is low tidal volume. Means tidal volume should be 4 to 6 ml per kg of the ideal body weight, not the original body weight. And plateau pressure should be less than 30 centimeter of water. Why? Because it is the plateau pressure which denote pressure at alveolar level, that you know from your knowledge of physiology. And barotrauma occurs at the level of alveoli. So you have to monitor pressure at the alveolar level, that is plateau pressure, and it must be less than 30 centimeter of water. PEEP, you know, positive end expiratory pressure means we are giving pressure at the end of expiration so that gas exchange can take place even during expiration, and alveoli always remain open. But PEEP, again, we are giving positive pressure all the time, positive pressure at alveolar level. So that can cause barotrauma. So they say start with minimum, that is 5 centimeter of water, and titrate. So all these things, these three things are done to prevent barotrauma. So we are protecting lung against barotrauma. And second, you know that oxygen toxicity can also cause significant ARDS. So oxygen should be less than 0.6, 60%. So this is very important. If you will have some question on, you can say critical care, either that will be related to oxygen delivery devices or maybe related to the lung protective strategy. Means you have to protect the lung against barotrauma and oxygen toxicity. CPCR, Again, in the CPCR, I'm going to CPCR, you must have read in detail in your medicine section. So I'm just going to tell you a few changes which has been recently introduced in AHA 2020 guidelines. Recovery, fourth chain of survival. Before, you know three things: basic life support, advanced life support, post cardiac arrest care. Finished. Now they say recovery. You should follow patient till he is completely recovered from emotional trauma, physical trauma, disability, rehabilitation, everything. Adrenaline, as soon as possible. Previously, it was also there, but now they say within 5 minutes. Previously, they used to say ASP, but no time. But now they say within 5 minutes. For layman, pulse check is not expected. So don't think that he can check the pulse. Means they should, if they're not able, then no problem. They can start CPR. And they say audio visual feedback. A special mechanism. When you apply over that during CPR, it will tell you what all mistakes you are making, and accordingly, you can keep on rectifying your CPR. Very important change, that respiratory rate now for pediatric age group is 20 to 30. Previously, you know, respiratory rate for all age group used to be 10. So adult it is still 10, while for pediatric they have increased 20 to 30 per minute from 10. So this is the most important change you can say in AHA 2020 guidelines. So if you get question, you can definitely expect a question on respiratory rate for pediatric age group. This is the most major change I will say. Rate has been increased to 20 to 30. Now, another important change, intraosseous. Intraosseous means directly into the medullary cavity. Now, intraosseous is preferred over endotracheal route, and anything can be given. Anything means not only drug, you can give even blood transfusion through intraosseous route, and it can be used at any age. Previously, intraosseous was only for children less than 6 years, but now it can be given at any age. So these are again important changes. Intraosseous, preferred or endotracheal, anything can be given and can be used at any age. So I think that should be all about uh, let me see if there are any queries. Sorry, my messages are not coming. Just a second. Give me a second. I will open the link. Okay. So let's see the messages of the OT Tech Guide. I personally believe proper placement DLT should be fiber optic, but some say no, capnometry. See, we didn't talk of DLT because double lumen tube is much beyond the scope of FMG. Yes. Double lumen tube means you are checking whether the tube is in right bronchus or left bronchus. That can be only checked by fiber optic bronchoscopy. Because capnography cannot tell you that CO2 is coming from right lung or left lung. It can only tell whether it is in trachea or esophagus. So endotracheal tube is confirmed with capnography, while double lumen tube you have to check with fiber optic bronchoscopy. Flow sensors. No, flow sensors doesn't measure CO2. Actually, it's a big discussion. Basically, some flow sensors, they are they are common flow sensors. They are taking all sample, but majority of the machines, EtCO2 is separate from flow sensor. So as a general, you can say no. Flow sensors do not measure EtCO2. I don't know, is it given like that? Then it is not correct. Let me see it. Yes, flow sensors measure tidal volume and other things, not EtCO2. So simply remember, flow sensor measures all kind of flow related tidal volume, airway pressures, but uh, capnometer measures the capnography. Bronchial intubation increase or decrease the EtCO2. Very interesting. See, actually, initially, just very initially, you will find decrease because CO2 is coming actually from one lung. But later, due to weak mismatch, CO2 will increase. So CO2 eventually is going to increase. So simply you can say that endobronchial intubation actually increases CO2 because of ventilation perfusion mismatch. Okay. Then somebody has asked, what about heparin? Uh, yeah, Raj Gautam, I'm doing good. Heparin, yes. Heparin, if it is, you just remember prophylactic. So low molecular weight heparin should be stopped 12 hours before. So we are talking of prophylactic dose. If specifically they give therapeutic dose, then we have to stop 24 hours. But if they don't give anything, then consider it as prophylactic dose and it should be stopped 12 hours before surgery. Okay. Any other doubt? I'll just wait for 1 minute. If somebody want to post any of the query, fine. If not, then I'll close my session. I think there are no more queries. So I think closing the session. Fine. Okay. Thank you very much and my best wishes.